Perfect. Hello and welcome everybody to this panel titled Reliable Insights Regarding Medication Outcomes from Real-World Data, Key Principles of an Evidence Generation Framework. My name is Rishi Desai. I'm an assistant professor at the Division of Pharmacoepidemiology and Economics at the Brigham and Women's Hospital and Harvard Medical School. And I will be providing introductory remarks for this session. So this is a brief history of the FDA's Sentinel system. In 2007, FDA Amendment Acts mandated FDA to establish and maintain an active surveillance system for monitoring drug safety using electronic medical records data, electronic healthcare data. Through the Sentinel initiative, FDA's aim is to assess post-marketing safety of approved medical products. Over the years, as you can see in this chart, the Sentinel program has undergone major development milestones. So since 2007, the FDA has first launched a pilot program, the Mini Sentinel, which was successful. And at the conclusion of that phase, the full-scale Sentinel program was introduced in 2016. Most recently, in 2019, FDA also established three major centers: the Sentinel Operations Center, Sentinel Innovation Center, as well as Community Building and Outreach Center. And the panelists for today represent the investigators and activities that are ongoing or planned for the Sentinel Innovation Center, where our main focus is to develop methods and supporting infrastructure to make sure we have a robust platform, robust system in place to monitor medication safety once they are on the market. So the current Sentinel system has 15 data partners. And if you glance through this list, you will immediately notice that most of these partners are big insurance companies or insurance programs, for example, Aetna or Medicare fee-for-service and so on. And through involvement of these major players in the insurance market, the Sentinel distributed database has been able to put together a comprehensive list of patients. So between 2000 and 2020, the 20-year period, the Sentinel distributed database has information on more than 350 million unique patient identifiers. Currently, the system is accruing data for roughly 71 million members. And this also translates to billions of pharmacy dispensing records and billions of unique medical encounters. So through the use of insurance systems, the Sentinel program has been able to put together information on electronic healthcare data for many, many patients, which enable the real-time monitoring of medications that newly enter the market. So to generate robust evidence, there are several components that are required from a data standpoint. So robust data sources are needed to generate decision grade or regulatory decision grade evidence regarding medication outcomes. So the first and foremost, the most important thing is to support causal conclusions regarding outcomes of medication. We need to establish a clear temporal sequence of events based on data from sources with nearly complete longitudinal capture. So this is what I'm showing in this cartoon, where you just, for an example patient, you have someone who had a medical encounter where he was diagnosed with influenza, for example, in 2017. Moving forward, this is another medical encounter where he has a hospitalization, and then moving forward, there is a diagnosis for a chronic condition. And you need all this information to be able to reliably identify patients' entire medical history, which is very, very important to attribute medication outcomes, initiation of a specific medication. And health insurance data are quite useful for this purpose, because regardless of where you receive your services, you will be captured through these insurance claims because these services are billed. And so health insurance, and that's the reason why the current Sentinel program has relied heavily on health insurance claims data, because it provides the longitudinality. On the other hand, the electronic health record sources in the US they lack interoperability. And so generally, in most cases, when you receive care outside of a specific setting or a specific healthcare system, your data is not captured. And that's one of the limitations of electronic healthcare data, electronic medical records in the US. However, on the flip side, there are limitations to the insurance claims as well. And because the insurance claims provide billing records, administrative records, there is oftentimes lack of details around clinical diagnosis, which becomes quite important when you're trying to evaluate certain outcomes just based on claims. So for example, if you are interested in outcomes such as tumor size or suicidal ideation, these are concepts that are just not available to you in great detail in just insurance claims records. So you need to rely on more detailed data that is captured through electronic healthcare records. Similarly, for laboratory-based outcomes such as neutropenia or drug-induced liver injury, that's the same case, because lab results are generally not captured in administrative insurance claims records. So you need additional clinical data to identify certain outcomes. It's also the case that in many cases you are missing information on key confounding variables. So these are the variables that impact treatment choice as well as they act as the outcome risk factors. And this includes things like your lifestyle factors, for example, smoking, alcohol use, or the vital signs, for example, or routine labs. They may act as confounding variables, and you need to account for them. But if you don't have them measured, such as in data sources such as insurance claims, it becomes much harder for you to control for these extraneous variables. And similarly, there are certain medical conditions where you are just not able to reliably identify population of your interest that you are interested in studying just using claims. So the point here is that each of the two data sources represent their unique strengths. With health insurance claims, you get the longitudinality. With electronic health records, you get the depth of clinical information that you require in many cases. So when they are linked, they provide really complementary information and may be able to address many limitations that are often encountered with just using one of the two sources. So linkage of electronic healthcare records to Medicare to claims is quite important. And so these are some of the challenges that we face in developing a robust evidence generation framework using real-world data. So the first and foremost is that sustainable infrastructure containing standing linkages between insurance claims and EHR is often difficult to achieve on a national scale. It's also important to envision a framework that is based on sound causal inference principle, because the evidence that we are generating through the Sentinel system is oftentimes quite influential in determining regulatory action, and we don't want to rely on just associations alone. We need to generate evidence that is causal in nature, and to do that you need to have a sound framework in place, so which is very much a focus of the Innovation Center. And outlining the principles of transparent communication is also quite important to increase confidence in the results that you generate. So our panelists today will be touching on each of these broad themes with respect to challenges in setting up the infrastructure, setting up a causal inference framework, and outlining principles for transparent communication. And this is just my final slide showing the initiatives and vision for the Sentinel Innovation Center, which is over the course of a 5-year period, we have put together a master plan containing activities in the areas of data infrastructure, feature engineering, causal inference, and detection analytics to provide the FDA with a query-ready, quality-check distributed network containing electronic health records, along with insurance claims for at least 10 million lives to enhance the current framework that we have in place for the Sentinel system. So with this introduction, I will hand this over to Dr. Sebastian Schneeweiss for our next section.
Yeah, thank you very much, Rishi, for having me on this panel, and thank you for setting the stage so nicely and providing an overview. My job over the next few minutes will be to review how we get from real-world data to real-world evidence that is robust for population-based decision-making, whether it is on a regulatory perspective or any other perspective of the general public. So I'm professor of medicine at Harvard Medical School and also the chief of the division of Pharmacoepidemiology and Pharmacoeconomics at the Brigham and Women's Hospital here in Boston. On the left side, you see my disclosures. You can pause the video stream to read those. I want to point out that pretty much everything that I'm saying here is well published in this review paper, which is open access. If you just Google Schneeweiss-Portone real-world evidence, then you will find a lengthy paper that summarizes our thinking of how to produce real-world evidence. Just a very quick review of the key use cases from a regulatory perspective. A use case for primary approval is where real-world evidence is used before the approval decision, the green vertical bar being the time of approval. That is largely limited to historical controls, external control arms, because the medication of interest is not in the marketplace, which means we cannot really observe anything in the real world of the medication use and its outcomes. But this is clearly a use case that is quite actively pursued in rare diseases for decades, actually. There's nothing new. And more recently, quite lively in the oncology world, but also increasingly in other conditions. Another use case is supplemental indications, where after the primary approval, the medication is marketed, and the manufacturer of the medication decides to push for an expansion of the labeled indication. That could be a different population, that could be a slightly different disease stage, it could be a different endpoint that they are requesting to add to their labeled indication. And there, of course, real-world evidence can be used because now the medication is in the marketplace, and real-world evidence studies can be conducted to support such a submission. We have accelerated pathways. They have different names for different regulators across the world, where the idea is that you get an initial approval with the commitment that you come back for full approval. And in the meantime, while in the marketplace, you use the opportunity to generate more evidence on the effectiveness and safety of the product. So that is a fairly straightforward in theory. And then, of course, we have the workhorse of where real-world evidence is doing for decades already, kind of the lion's share, which is the safety signal identification and the characterization of any safety issues, which can happen right after approval, as signals pop up in the authorization trials, and that will be worked up as post-marketing requirements or past studies, or safety signals pop up out of the blue and they need to be worked up. All of these things have in common that we need to understand the causal relationship between drug use and health outcomes. Associations alone, where we cannot differentiate whether it's the drug that is producing health outcome or whether it's the disease in itself that is making things worse or better because it's an episodic condition, that needs to be disentangled. For that, of course, we love randomized controlled trials, and it's in the upper left corner, a schematic that shows how these trials work, and you all are very familiar with that. You identify the population of interest. You have a washout period or a run-in period, and then R stands for randomization. You randomize your individuals into those exposed to the drug of interest and those who will be exposed to a comparator drug, and for approval studies, often a placebo tablet. And the complementary study design in the non-randomized world is the cohort study. In a cohort study, you also will identify subject of interest. Let's say everybody has type 2 diabetes, for example. And then you mimic a washout period by requiring new use of the drugs of interest, no prior use. But the key difference, of course, is instead of an R, here you have an S. S for selection, because these patients now select themselves, together with their physicians, of course, into users of the drug of interest, exposed, versus users of a alternative medication that is treating the same condition, the comparator agent, right? So structurally is very similar in design, is mimicking the trial, the target trial that we contemplate, but we cannot conduct for whatever reason. We are running out of time, we are running out of money, it's unethical to randomize at this point. There are various reasons why you cannot do the trial, but you can mimic, you can emulate that trial. And the design that you see down here is the new user active comparator cohort study design, which has proven quite valuable for many of these questions that we have. I call this a causal study design. And you see a paper here on the right side that helps reviewers, or is supposed to help reviewers who are familiar with reviewing RCTs. What are the additional things that you have to pay attention to when you review real-world evidence studies, right? What is different from RCTs with primary data collection when you move over to non-randomized with secondary data collection? And this is very much derived from this 3-layered cake that we use for doing these studies. It's a very repetitive task, really, if you do these studies. You have a design layer where you decide what is the primary study design. Do you want to have a controlled study design or a self-controlled study design? These are two. There's a fundamental choice here. You get different answers often because you have a different causal question. And you had bias reduction strategies within those designs. This new user-active comparator design is reducing biases. The causal temporality is critical, that the exposure comes before the outcome. This seems trivial, but believe me, we see many publications where this is getting confused. And then the confounder information, of course, needs to be measured before the exposure starts. Then comes the measurement layer. And I think particularly for this audience, that is where you contribute quite a bit, where in the end, we need 4 types of variables in order to conduct these real-world evidence studies. We need to identify the exposure of interest, the drug of interest versus a comparator drug. We need to identify the outcome of interest. And if we cannot measure the outcome of interest, we don't even have to start trying to do the study in that data source. We have to move on to another data source if we want to work with secondary data. We need to identify confounding factors in the absence of baseline randomization. And of course, we need to be able to identify the study population in the very first place. If we want to study patients with type 2 diabetes, we need to be able to identify people with type 2 diabetes. So there are a variety of data sources, and they can be very structured, coded information, semi-structured lab test results, and unstructured information. This needs to be processed and pre-processed in order to inform those 4 key types of variables. This is all we need, but it's often a difficult path to get there with sufficiently granular information, complete information. And then comes the analytic layer, which is not that different from randomized controlled trials, except of course that we don't have the baseline randomization. We need to balance these cohorts that we compare with regression models, with propensity score strategies and derivatives thereof. And then often in the absence of baseline randomization, work with secondary data, we like to do sensitivity analysis to check the robustness of our findings. So this is kind of the basic cookbook for doing real-world evidence studies. A key difference to RCT number 1 is that we don't have baseline randomization, which is obvious, and it's always the first thing that pops into people's mind. But equally important, if not more important, is with most RCTs, we work with primary data. And when we work with real-world evidence, particularly following the FDA definition of real-world evidence, we're working with secondary data, where we were not in charge of what to measure, when to measure, and how to measure. There's a key difference, and let's not forget that. When we then move on to these external control arms, or use case number 1, as you recall, which is simply this, a linear thing. You identify patients and they will be exposed, right? And then you have this external control arm, which mimics the experimental arm, but it's not randomized. It's not starting out with the same source population, which causes the key difference number 3 to an RCT, which means that you might have differential data quality. You might have often primary data collection in the trial, in the single arm trial, and secondary data in the ECA. So that is another layer of complication in the measurement layer, in the second layer of the cake. Now, what is critically important when you want to make recommendations how to treat entire populations, your research needs to be reproducible. And high transparency leads to reproducibility. And Shirley Wang has done a series of studies, starting out with a pilot with replicating 32 published studies and then identifying 150 published database studies, real-world evidence studies, and reproduced with her team these 150 studies in the same data. but based on the set of instructions that were provided in the publication. And what you see is, well, there's of course some agreement, but there's also disagreement. So there's room for improvement, which triggered this activity here between academics and regulators around the world and industry to develop a structured reporting template that makes sure that all the parameters, the study parameters that need to be known in order to make a study reproducible will be recorded in a fairly standardized way. And that is picked up, and we are now in a phase of consensus finding between different professional groups, and ICH is involved, the regulators are involved, and I think we are moving towards a convergence about how the studies will be or should be reported and how protocols should be written in order to be fully transparent. That's transparency. Once we understand what exactly was done, the next question is, well, was this study now valid? Does this study lead to causal conclusions? And this is where our FDA-funded project, RC Duplicate, is coming in, where we identified 30 randomized controlled trials that were designed to be presented to regulators, and most of them were presented. We developed a structured process of how to check in the feasibility and the quality of the potential study before we actually do the study, and then submit the study to our colleagues at the FDA for reanalysis, using a standardized software platform that is used by the regulator as well as by us in order to have a shared platform with data and analytics, and is resulting in a graph like this. Where you now have then in the end 30, I think here are only 20 plotted, 20 trials, and the emulated real-world evidence studies we compare the findings of those. Here you see this magnified. Ideally, you would expect these blue dots to be ideally on the green diagonal, where then the parameter estimate, the effect estimate from the real evidence study would be exactly the same as the effect estimate from the randomized controlled trial. And that, of course, is not always the case. Now we have to disentangle that. So one observation that we see is that in real-world evidence, in two variables, age and sex, which we measure very well in claims data and other secondary data sources, we observe that most of the time, the study population with real-world data is older. Although we have the same age range in our inclusion-exclusion criteria, still we have an older distribution. And the same is true for the sex distribution, real-world evidence. We have we know that in randomized trials, they have difficulty enrolling women, and they underrepresent women often in the experimental studies. And the consequence thereof is that when you look at the Kaplan-Meier of the trial and then of the real-world evidence emulation, these curves are kind of downshifted, sometimes upshifted, but most of the time downshifted, which means that the incidence rate, we're studying a slightly different population, is less risk for developing the outcome. So the incidence rates are lower, but nevertheless, the point estimates might very well be the same as you see when comparing these two pairs of Kaplan-Meiers from the RCT and the real-world evidence study. And this results in tables like this here, where in the bottom half here, you see 4 diabetes trials, and you see the RCT result here, the beneficial effect, and you see the real-world evidence emulation. There's great agreement here for a variety of reasons that I cannot get into here at this point. Similarly for direct oral anticoagulants, 3 trials here with regard to stroke prevention. You see the trial findings and you see the real-world evidence findings. So there's great agreement, right? There are other examples among the 30 trials, and let's look at Horizon Pivotal, for example. It's quite a distance away from the green diagonal. So what was going on here? And the trial is on zoledronic acid versus placebo. Zoledronic acid is a osteoporosis medication and is supposed to prevent bone fractures. And we mimic that versus an active comparator, raloxifene, rather than placebo. This is the finding. In the RCT, they found this 41% reduction in hip fracture incidence. 40%, 41%. We find only a 25%. While directionally it's the same, it's a substantial difference nevertheless in the point estimate, and we were worried about this. And what you see is that in the RCT, the follow-up time is 36 months. While if in our emulation with claims data, the follow-up time ends at 18 months because there was basically nobody who got a second dose of zoledronic acid, which is given once a year. It's an infusible agent once a year. So we truncated follow-up at 18 months. So we're really reporting the 18 months finding. We don't know what the 36 months effect is in clinical practice. But if you then look in a randomized trial at the first 18 months, you actually get exactly the same finding. So what this is a trial that is very difficult to emulate because the practice pattern is different. We don't see this long-term adherence. But in the evidence that is overlapping that we can emulate kind of the early 18 months, we actually see exactly the same finding. So it's a success, nevertheless, because we can replicate the randomized trial finding. And we have multiple of those use cases. So that overall, our conclusion is that in those settings where the randomized trials can be emulated well, and that is about the case in 2/3 of our predefined trials, and if the data are fit for purpose, then we can come to the same causal conclusions. Nevertheless, these highly controlled randomized controlled trials, they're highly controlled for a reason, obviously, and some of these characteristics are simply not emulatable. They are designed for different purposes to demonstrate efficacy, not effectiveness in clinical practice. Just going back to the middle layer, the data quality, this is just to remind us to look at these 4 key characteristics that we're interested in. And if you think backwards from the principles of causal inference, what we want to know for each of those 4 types of variables, we want to know their measurement characteristics. How well are we measuring these things? What's the sensitivity, the specificity, the positive predictive value? For continuous data, what's the percent missing? What's the mean squared deviation? The accuracy of the onset date? This is what we would like to know. Unfortunately, more often than not, we don't have that information. And we work with proxies thereof, and we have lots of strategies in order to improve measurement characteristics. But often enough, we don't know the exact measurement characteristics. What we are seeing, and this is tying to what Rishi already said, to more linkage between data sources that have different strengths. Linking claims with electronic health record is an obvious thing. Continuity in claims and clinical granularity in EHR. Linkage with lab test results, rather than knowing what test was ordered, but also knowing the result. Linkage with accurate death date and the cause of death information is very, very helpful and useful. And we see more and more specialty registries. And I think this is a field that is expanding dramatically as we speak in oncology, obviously, but we see it in other fields, in ophthalmology, urology, neurology, more and more specialty registries that can be used for real-world evidence analysis. And there are many guidance documents out there, and I'm not going into detail. Many of them focus on transparency and process. There are also step-by-step guidances of how to do these studies and how to report them accurately. But in the end, what we all aim together to do is we want to turn real-world data into real-world evidence that lends itself to causal conclusions. And in that effort, real-world evidence complements RCT evidence. This is not either or. This is always, we want to have both. They complement each other. And the 3 conclusions that I have here is that as we follow the principles of causal study design and analysis and inference, we will get closer to this goal. And of course, we know how to. We know how to do causal studies and causal analyses. And we're also getting closer to our goal as we reduce human error and increase transparency, and we know how to. And also as data sources are improving, which they do rapidly. So I think there's movement on all fronts. We have solved many issues already, and there's a dramatic dynamic in other aspects. This is moving very quickly towards a very promising destination. So I'm very upbeat on real-world evidence and its utility for serious decision-making by regulators and other high-stakes decision makers. So thank you very much, and I hand back to Rishi.
Thank you, Sebastian. The next panelist will be Dr. Keith Marsolo. So Keith, if you can share your screen.
Great, thanks Rishi, and thanks everyone for having me as part of this panel. So I'm Keith Marsolo, an associate professor in the Duke University School of Medicine in the Department of Population Health Sciences, and then I am also a member of the Duke Clinical Research Institute. And so today I'll talk a little bit around data quality, and Sebastian touched on sort of fitness for use. And so I'll talk a little bit about that, what we're doing within a network called PCORNet. So just a couple of disclosures. I think probably most important is that what I report here are sort of my opinions. I'm not representing PCORI or the PCORI Board of Governors. So just talk a little bit around what we learned about PCORNet. So PCORNet is a network of networks. It's made of clinical research networks, academic medical centers, health systems, federally qualified health centers, some health plans, patient partners, and then a coordinating center, of which the Duke Clinical Research Institute is a part. And so all that makes up the PCORNet infrastructure. It functions as a distributed research network, so actually very similar to the Sentinel network. Sentinel is mostly claims based, and PCORNet is mostly an EHR-based network. But the general logistics are the same, where partners harmonize their data into a common data model, and then queries are packaged up by the coordinating center and then sent to the partners, and then the results come back in the form of typically aggregate results or summary statistics, although we certainly have the ability to transfer patient level data if needed for study. So in terms of the PCORNet data model, it has many of the domains that you would expect to see within electronic health records. So diagnoses, medication orders, medication administrations, demographics, procedures, vital statistics, labs, and then there's some death information and some claims. So all of that is pretty well harmonized. And then we also do have in sort of pockets of the network, some of the more sort of innovative or advanced domains, social determinants of health, tumor registries, patient-reported outcomes, genomic results, information derived from natural language processing. That's not really scaled across the entire network at this point, but it is something that we work on in pilot studies, and then learn from that, and then gradually work to expand the utilization across the network. So we spend a lot of time within PCORNet focusing on data quality and moving the raw EHR data to something closer to fit for purpose data. And so we tend to follow a two-stage process to determine fitness for use. And so this is a graphic that came out of a publication from the Duke Margolis Center, talking about sort of a minimum process for assessing real-world data. So going from a sort of the raw data to a stage one, kind of a research-ready data set, where you're running a foundational curation process to establish a baseline level of quality, and then really a second set of analyses or transformations where you're ensuring that the data are fit for purpose for a given study or analysis. And that sort of two-stage process, foundational and study-specific, is really what we utilize within PCORNet. But I think it's important to note that this process is not static. It is a sort of a continuous learning process, and so there's a continuous assessment of performance and a revision of data checks or thresholds based on sort of what we're finding. And then, I think probably more importantly is working to close that gap between foundational and study-specific curation, so that you can add new data checks based on study findings. So when we talk about fit for purpose, it actually is somewhat of a nebulous concept. And so I think Bob is going to speak more about this towards the end of the panel. But we do look at the FDA definition of fit for purpose, and really when they talk about fit for purpose, they view it in terms of relevance. The relevance of the source and the reliability of the source. And so Sebastian talked a lot about in his presentation, actually focused on elements of relevance. And so looking at exposures, outcomes, confounders, those key elements, are they part of the data set? And then is the population represented? So that's a key component of what you look at, is really the relevance of the source. But then it's also important to assess the reliability. And so in previous versions of the guidance, reliability was often framed in terms of data accrual, and then sort of data assessments. And in the latest guidance from the FDA that came out earlier this month, the draft guidance, was really geared more towards EHR and claim sources, talked about it just in terms of measures of data quality, and so things like accuracy, completeness, provenance, traceability, and then just more information around just the general process of curation and transformation. And so really from a reliability perspective, if you're looking at the data from the original source system and then the data as it exists in a study-specific data set, sort of, can you trace the evolution of the data or the fidelity of the data from one to the other? And so when we think about the data checks that are done within PCORNet and really within most sort of distributed networks that work on EHR data, foundational curation is really focused on reliability, and then study-specific curation is really more around relevance. And you might ask, sort of why is that? And while PCORNet has been working for 5 or 6 years, in reality, most of the EHR data outside of things like demographics, diagnoses, and some procedure data, most of the domains that are in the EHR are really being harmonized or standardized for the first time. And so given the volume of data, it's pretty overwhelming to assess sort of some of the foundational structural components of data quality, while also addressing study-specific or population-specific questions at the same time. It's just the volume is really quite large. And so just to give an example, these are some numbers from PCORNet, where the bars represent the growth of lab data within the network over time. And so you can see that it's in sort of record of billions. And so you can see that we started maybe in 2016 with around 2.5 billion lab records across the network. And we're now approaching 13 billion lab records. And then the other thing I think that's important to note is actually the number of sort of the median number of tests that those billions of records represent. And so and that's the line, and you can see the scale on the left side, where we're approaching 2,300, 2,400 unique LOINC codes or lab tests within the system. And so if you think about trying to make sure that all those data are of high quality, structured correctly, using the right codes and everything, that's a ton of work to do, and it becomes even more challenge if you're trying to address that within a particular population, time frame, care setting, things of that nature. And so that's really why we tend to separate sort of the foundational and the study specific. So just sort of another example of some of the harmonization work that needs to happen. And this is just an example of some of the visit types, sort of the columns on the left side, or what you might see in the electronic health record, where you've got 150 or 175 different encounter types. And these are all very important for sort of operational purposes, could be for improvement purposes or even billing purposes. But when we're thinking about things for some of the pharmacoepidemiology studies that Sebastian is talking about, really we care about a much smaller value set. And so then there's an exercise within each of the health systems as they map their data to the appropriate encounter. And so, just focusing on getting that right is a job in and of itself. And so when we're talking about foundational data checks within a network, these are some of the questions that we sort of ask when we're designing a check. And so some of the more simple ones are really, does the record simply conform to the structure of the format of the common data model? And so if the value set for a record is 1, 2, 3, is that what we're seeing in the data? If it's a integer versus text, sort of those sort of basic things. And then, you can start to make things slightly more complicated. So, our record's internally consistent. And so if you have a lab test for a urinalysis, for instance, is the specimen urine or is the site reporting that it's a blood sample? And so if you've got that mismatch there, you need to check, is it the right code or did they just, choose the wrong specimen source? And so those are some of the things that you can check based on the data. If you're going to use it in an analysis, are all the necessary fields populated? So if you want to use again, a lab value, do you have the sort of the test code so you can figure out what kind of test it is? Do you have an actual value in the record? Do you have a unit so that you know how to interpret the results and you're not trying to sort of infer it based on the information that you have? And then you can start talking about some of the plausibility kinds of things. Do the values that you're seeing or the distribution that you're seeing, do they make sense? Now, you can come up with some of these examples, if you're sort of thinking about it from an analysis perspective, of thinking you're going to have a clean data set. It's relatively easy to sort of design these checks in a vacuum. But I think it's important to keep in mind, that some fraction of the data will always be dirty. And in fact, if you don't see errors in the data, that's usually a problem, because that usually means that somebody is sort of cleaning the information upstream. And if you don't know what they're doing, you don't know that you can sort of trust what they've given to you. I think the other thing to note is that EHRs change over time. And so, older data, particularly before 2014 or so, when some of the federal meaningful use legislation came into place that standardized things like demographics and things, the information was more variable, less standardized. There was sort of less use of EHRs, sort of enterprise EHRs. I think there were a lot of custom homegrown systems, and so the data gets spottier the further back that you go. And then I think the other thing is that you do need to allow for variation in population or practice patterns. So an example within PCORnet is if we've got a measure for plausible blood pressure values, and we wanted to apply to the entire network, a pediatric children's hospital, their blood pressure values are actually going to look very different, and in fact look like they're errors compared to an adult population or a mixed population. And so, those are just some of the things that you need to think about when you're designing these checks. And then those factors can help determine sort of what's required. And typically within distributed networks, like required checks mean if you're sort of failing what's there, you need to fix it before you can sort of use the data for any kind of querying or analysis. And then the other option is something that you would consider to be optional, or in PCORnet we label it as investigative, where really it's just understanding from the site what's the reason for the error, and then that can inform any study that wants to use those data, whether the issue that is at play is going to be a factor given their design. So in terms of the types of data checks that we use in PCORnet, so I talked a little bit about conformance. We talk about completeness, where we've got values that appear where we expect them. And then sort of plausibility. I think some of those, if folks are familiar with the framework from Michael Kahn around sort of data quality, I think those map very well. I think the other thing that we've added in PCORnet, based on what we've seen, is what we call persistence checks, where we're looking at patients or records, making sure that they don't disappear between refreshes, because EHRs are sort of live transactional systems, and there's sort of lots of changes that can occur. And so, we've had to put these checks in place to make sure that that things are not disappearing when they shouldn't be. Sometimes, there can be valid reasons where somebody's sort of cleaning up a legacy system, or they lose a feed for a hospital or something like that. But in general, we don't expect data to be disappearing, and so that was just something that we ended up needing to monitor. And so the graph on the right illustrates the sort of the growth of the data checks within PCORNet. And so the bars represent sort of the number of data checks that we have, and then the different categories. And so we're approaching 38 data checks, and then sort of each of those checks can be translated to look at sort of multiple things with the data model. So we call those data check measures. For instance, if we're looking at the required that all the tables be sort of present, and that if there's 20 tables in the data model, that might be 20 different things that we check. And so we're up around 1,400 or so measures that we look at sort of every time that the data are refreshed. So when we talk about the data check failures, and all of this comes into play when we're discussing sort of fitness for use, we tend to categorize the causes of the checks into sort of whether something is non-remediable, it can't be fixed, or it's remediable and it is something that could potentially be addressed. And so, the ones that are sort of not fixable, those tend to be based on, obviously the population characteristics. So if you've got a pediatric population, and there's some adult-focused data checks, that's just not something that's going to be there. Or there's going to be, source system limitations that cause the data to not exist, or the system is basically producing an artifact that needs to be addressed within the data, where it's hard coding future dates to encounters or something like that, or scheduled encounters or something where it's something that you want filtered out of your data set, because it's never going to be quote unquote fixed. Some of the fixable ones, and these are obviously where we spend more of our time as a network, looking at the mapping from source systems to a reference terminology. So if you've got local lab tests, to mapping those to a lab standard like LOINC, or medications to a terminology like RX norm, or the CDM value set. And then the other that we see, given the systems that we work with, are sort of source system limitations, where the team that are working with the common data model or populating the common data model may not have access to the ancillary systems that are used to store that information. So an example where this occurs a lot is in cardiology, where things like ejection fraction, your echo results, they're going to be stored in a separate system that maybe doesn't talk with the EHR, and it's sort of managed by an IT group within the clinic or something like that. And so sometimes you need to make connections within the health system to get access to these extra systems, or legacy data or something like that. And then we also look at sort of issues that are introduced by the transformation process. And I think the other thing that we always need to keep in mind is that not every check will be sort of fixable by every site. Some sites just, they may be where they are, and they can't really improve their performance. And so again, it's really around making sure that, assessing whether or not that site is sort of fit for purpose based on the question of the study or the analysis that you're doing. So, we have, as I said, we focus on things that we feel to be, things that we can improve. And we do have some baseline measures, and you can see here in this graph some of the key foundational checks that we actually have made substantial progress as a network. If you look at where we started in 2016 for things like, percentage of medications that are mapped to a preferred RX norm code, or, lab tests that are mapped to LOINC. And then things like the latency of the encounter information. So, we try to say that when you refresh the data, basically the encounters sort of present in the system are that you have data from the last 3 months, basically. And you can see that we've made some pretty good improvement on those measures over time, where sometimes it's around 50%, and then we're sort of 80-90%. As a network. I think the one note on this graph for the latency check, there's a drop That was due to the pandemic. The way that we calculate latency is sort of based on it's a historical volume-based measurement, and when everything shut down because of the pandemic, there was obviously very little volume, so it made look like information was not complete. But you see that we've pretty much rebounded from that now. So I talked a little bit around curation as a learning process. So it's not static. We do update things over time. So just talking a little bit around findings from influenced by the design of the common data model, and then basically some of the study findings, because I think that's important for bringing in those study-specific characterizations into the foundational process. So one of the things that we did very early on, so during this refresh process, we were identifying errors, and it surfaced issues where there was ambiguity in the CDM specification itself. So, what happens if you know that the patient is dead, but you don't actually know the date of death, right? It's a historical sort of import from a legacy system, so you just don't have that information. Or there's complexity in the source data, and so we saw this particular issue a lot in some of the historical data, where race and ethnicity were captured together. Hispanic was listed as a category under race, not as a separate field that it typically is today. So we would get these questions, and people would ask sort of, how do I represent the information that I have in the data model? And so one of the things that we've done over time is add in this implementation guidance to the specification to reduce variability and sort of improve our downstream analytics. And so we've got sort of general guidance that applies to the entire data model itself. How do you handle future dates or sort of ages over the age of 89 or something like that. And then we've got specific table guidance that might only be, in this case, relevant to encounters or procedures or diagnoses. And then we've got field level guidance as well, where, sort of specific questions related to that field. And we've sort of got the ability to add that, to iterate that over time. And then, thinking about bringing in information from studies to help improve the process. So this is a data check that we introduced based on the adaptable trial, which was a recently concluded pragmatic trial looking at the comparative effectiveness between sort of low dose aspirin and high dose aspirin. So, I sort of talked a little bit about latency. And so, the issue here is, there's sort of, you can see the sort of events in the graph on the left where, the patient's enrolled in the trial, they've got some visits, a prescription, a lab, and then, sort of there's a blank spot, and then there's a query date within the data model. And so when you've got that blank spot, it's important to understand, do you have no events or just no data? And so, I think this is a good contrast from maybe what we would see in some of the claim sources that sort of Sebastian mentioned, where you've got this concept of enrollment and the idea of complete capture of sort of all the information within that enrollment period. So we don't necessarily have that with EHRs. And so, we need to know if there's nothing there, again, no events or no data. And so the check that we created was the latency check, where we look at the historical volume for, each of the tables, and look at sort of the previous, sort of the 13 to 24 months previous to get sort of the average volume. And then we look at the most recent 12 months. And then we basically say sort of what's the most recent date where there's sort of any information. And then, we look at the date when we would say that there's complete, and that's sort of, what we'd say is 75% of the benchmark. And that can help you understand, again, whether or not the information that you've got is going to work for the study or the analysis that you're doing. And so, just a couple of things at the end. So, we're working to assess, better assess the source to data model mappings, understanding the impact of harmonization and mitigation strategies, and then closing the gap between, as I said, more foundational and study-specific curation, including more cohort-specific assessments in the foundational process. So just closing. So the issues here, it's inherent to EHR data, not specific to PCORNet. Process for continuous improvement, and continue to share, develop and share best practices and how they translate to the FDA guidance. And then Sebastian talked a lot about all the great work that's happened around administrative claims. And so I think, there's been years and years understanding the pitfalls. And so, just taking time to develop that knowledge around the EHR. So thank you.
Great, thank you, Keith, for the very comprehensive and excellent introduction to data infrastructure issues. Now, the next speaker is Dr. Shirley Wang, and Shirley, if you can, thank you.
Hi, I'm Shirley Wang from Brigham and Women's Hospital, Harvard Medical School, and thanks for the opportunity to speak to you about some recent efforts to encourage reproducibility and transparency of RWE studies and tools to facilitate appropriate interpretation of results. Now, Sebastian touched on a few of these earlier, but I'll go into a little more depth. I plan to speak at a high level about 6 related activities focusing on increasing clarity of research reporting and reproducibility of real-world evidence studies. But before diving into those, I want to briefly touch on why this is important for the field. So obviously, reproducibility is a very important core scientific principle, but there's been concerns about lack of reproducible research across many scientific fields, including cancer biology, psychology, economics, bioinformatics, as well as clinical trials. And recently, there have been several large-scale efforts to evaluate the replicability of those studies in these disciplines, with results suggesting that there's room for improvement. And our own field is not exempt from this, so I'll be talking in a few minutes about efforts to improve reproducibility for real-world data analyses. Now, improving reproducibility is important because the end goal of generating evidence from real-world data is to help inform decisions about the benefit, harm, or value of medical interventions. But to do this, we need to have confidence in the scientific approach. Is it valid? Is it robust? Is the evidence transportable to different populations? And in order to have that confidence, we need to understand how the evidence was generated. And it's at this foundational step that we have our initial hurdle to get over, where lack of clarity in reporting is a barrier to use of real-world evidence in decision-making because of the high ambiguity about how the evidence is generated. It makes it difficult to reproduce findings, assess the validity of methods, or evaluate their relevance for the question of interest. So now I'll highlight some of the recent past and ongoing work in this area for studies conducted using routinely collected healthcare data from claims and electronic health records. And I'll start with the first joint task force between the International Society of Pharmacoepidemiology and the International Society of Pharmacoeconomics and Outcomes Research, which was focused on transparency to increase the credibility of RWE for healthcare decision-making. So for one of the deliverables of this joint task force, what we did was create a comprehensive catalog of operational parameters and design decisions that an investigator makes when implementing a study using healthcare databases. And in contrast to existing guidance, which tends to be a bit general to cover a broad base, we try to be very specific about the decisions that are made when moving from longitudinal healthcare data, which are anchored in calendar time, to create an analytic cohort that's appropriately anchored in patient event time. And this level of clarity and communication about study implementation is necessary for both reproducible evidence and evaluation of validity. So following that first joint task force as part of the REPEAT initiative, we've been working on evaluating the reproducibility of 150 published descriptive and comparative effectiveness or safety studies by attempting to independently reproduce them using the same methods reported in the paper applied to the same research databases as the original investigators. And we carried out these study reproductions blinded to study results to maintain independence. When a scientific decision was not clear, we had a system for making and documenting our assumptions. Now, independent reproducibility depends on unambiguous communication about a study's scientific decisions. And for this project, we evaluated how clearly those decisions were communicated and how that related to our ability to reproduce studies. As a side note, this high level of clarity in implementation is also critically important when trying to translate a common protocol for implementation in multiple data sources with different data structures. So in this reproduction effort, generally what we saw was that there was a bolus of studies that we were able to closely reproduce, but also a substantial minority that we were not able to reproduce closely, even when using the same data sources and trying to implement the same methods. And there were 3 main reasons why we had difficulty reproducing studies. First, we struggled when there was incomplete information on details of key design parameters. We particularly noted lack of clarity regarding when study parameters were measured relative to the study entry date, as well as the absence of detailed code algorithms. Second, we struggled because of incomplete information about data version. Although we did use the same years of data from the same data sources as the original authors, these data are not static. Retroactive updates to the data can shift the underlying population, as well as how certain variables are populated. For example, we know that one of the data sources we used changed how death was captured in different ETLs, in one version not including deaths from the Social Security Death Index. A third reason we struggled to reproduce studies was that we saw internally inconsistent information between the text, attrition tables, and diagrams, which forced us to make assumptions about what was actually implemented. Now, going back to the first ISBIS-4 Joint Task Force for a moment, one of the recommended items to prepare and share for RWE study reproducibility was a design diagram. So we proposed a framework for graphical depiction of study design in a follow-up paper. Before diving into study design visualization, I just wanted to quickly talk about what we typically see in our healthcare utilization databases. As you know, we capture things when there are encounters with the healthcare system, such as associated diagnoses, procedures, prescriptions, dispensings, notes, and other documentation. This information can be visualized longitudinally in calendar time, with lines representing points in time, such as an outpatient encounter, and wider intervals representing duration of inpatient stay or day supply and things like that. As shown here on the left, patient history across calendar time can be visually represented for multiple patients in the data. But when we do our research studies, we need to create analytic data sets that are anchored on patient event time. And this is shown in the right-hand figure, where time is now anchored around a first prescription for a drug of interest, which is denoted as day 0. This alignment of person time anchored on a patient event rather than calendar time helps us to be clear about what is measured in baseline versus follow-up. In the end, what we typically analyze is a clean flat file consisting of mostly ones and zeros. But in order to appropriately interpret findings from real-world evidence studies, it's important for reviewers and decision makers to understand how that series of ones and zeros was created and whether there are validity issues that would help change their level of confidence in the results. And this is where design diagrams can be helpful as a way to concisely summarize and communicate those key study parameters. Here's an example diagram for a fairly simple and straightforward study that evaluated the risk of angioedema with ACE inhibitors compared to angiotensin receptor blockers. And on the left here, I've highlighted a methods section describing the study design. All of this information is represented in the diagram, which is intended to be read from top to bottom and show the sequence of actions that are taken to create the analytic cohort. The vertical gray arrow is used to represent day 0, the point at which the study entry defining criterion is met. And the size and location of the horizontal bars visually show the assessment windows for inclusion-exclusion criteria, covariates, and follow-up, all relative to day 0. And in addition to the visual representation, there's bracketed numbers within each bar that uses standard mathematical notation to explicitly specify temporality. The diagram can be helpful in spotting potential validity concerns. For example, if we were to see a covariate assessment window that stretched from before cohort entry into follow-up, this should catch our attention and lead us to carefully consider whether we're concerned about looking into the future to measure baseline risk factors or adjustment of causal intermediates. In a recent paper by Laura Happy, editor of JMCP, she found that only 42% of real-world evidence studies published in her journal had any design diagram at all, despite this being strongly recommended at the time of submission. As an exercise, she tried using the visualization framework to diagram the design for 2 studies recently published in the journal. And she noted that ambiguity in the text did not permit her to diagram the study design with confidence that the diagram would be an accurate reflection of what was actually implemented. So that brings me back to making the case for using design visualization to increase transparency and facilitate reproducibility as well as validity assessment. Design visualization is a tool that can be used when planning a study, helping the investigator to think about time, measurement windows, and potential biases. Having prepared this in the planning phase, the visualization becomes a reporting tool, helping to facilitate unambiguous communication. And once shared, it provides end users with key information needed to make assessments of validity. So building off all of this prior and parallel work, we worked with the FDA in a public-private collaboration to develop a structured study planning and implementation template called START RWE. And clearly there are already existing guidance documents and checklists that apply to these types of studies. But what was new with START RWE was the level of technical detail to help support study planning, implementation, and reporting. Currently, ambiguity in communication of these key study parameters makes it difficult for reviewers to assess potential for bias, and this may limit their utility in healthcare decision-making. The template is designed to reduce the ambiguity by creating a common structure that helps research teams be clear and comprehensive in first planning and then communicating their intended scientific decisions. The START RWE template is essentially a very structured series of tables and a figure for detailing study design and implementation. The template includes a table detailing version history with rationale for changes. For example, over the process of developing and implementing a protocol, you might have an initial version for first feasibility counts, looking at outcomes that are not stratified by exposure. In version 2, using revised algorithms to generate second feasibility counts, making sure you have enough power, and doing diagnostics like assessing balance on propensity score variables. And in version 3, using finalized algorithms for inclusion-exclusion criteria and covariates to implement the actual analysis. There's also a structured table for detailing sensitivity analyses and the rationale for conducting them. In other words, stating what you intend to learn from doing the sensitivity analysis. This rationale is especially important to help end users make sense of and interpret the findings, particularly in a discipline where it's easy to run many sensitivity analyses. And it's difficult to walk through the template's structured tables in a PowerPoint format, but I'll quickly discuss the design diagram figure and parts of one of the main tables summarizing study population parameters. So the figure in the template is a design diagram that we talked about earlier, which provides that concise visual summary of how the analytic cohort was created, almost like an abstract. And there were PowerPoint templates published with the paper, or you can use a web-based R-Shiny app to help you create publication quality figures to scale. So just to briefly show table 3, the summary table for study parameters. This table provides more detail than the design diagram, starting in subsection A with metadata about the data sources, and things like data version, extraction date, data linkage, or conversion to a common data model are summarized in this table with more detail in appendices. Without going into the technical detail, the subsections underneath describe in a very structured way the operational definitions for key study parameters, such as day 0 for entry to the study population, inclusion-exclusion criteria, covariates, and outcomes. There are fields in the table to specify things like how variables enter models, as well as the performance or validation of outcome algorithms. There's also a structured section to define when follow-up begins relative to cohort entry and how it ends. This helps the investigator consider each option and make an active choice. It also makes it clear for the reviewer what is and is not used to end follow-up. In the interest of time, I won't walk through all of the tables, but will point out that the tables in the template are intended to be accompanied by machine-readable appendices that list out clinical code algorithms used to define study parameters, as well as appendices to detail other things, like decisions made when converting source data to a common data model or doing data linkage. But to summarize, the goal of START RWE is to help research teams be clear about intended scientific decisions and allow other researchers or reviewers to be on the same page about those decisions. The idea is to have clarity to the point that the work could be independently reproduced, and this clear understanding would facilitate assessment for bias. The START RWE template tries to achieve this by creating a common tabular and visual framework so that multidisciplinary research teams and reviewers of their work will know what to look for and where to find it. Moving on to the next related workstream that I want to briefly touch on. As many of you know, the International Council on Harmonization, ICH, a nonprofit organization that brings together international regulatory authorities and pharmaceutical companies. They have a short-term strategic priority focused on harmonizing the technical and scientific requirements for studies submitted for regulatory consideration. And this prompted the second Joint ISBIS-4 task force, which is focused right now on harmonizing across existing protocol templates, checklists, and other tools. In our initial months, we focused on doing a landscape review of prior and parallel work streams. We searched the Equator Network, PubMed, as well as used snowball identification of templates through experts. And we identified 4 templates to harmonize, including START RWE, the EMA PASS protocol template, the NSCC template, and ISBI's protocol guidance. We realized that while there's been a lot of activity from different groups, there's no major discrepancies on the overarching principles. However, there is variation in the level of detail or the standard for transparency set by different tools. We've mapped the sections of these templates to each other, highlighting the commonalities, as well as the different structures and information content requested. And we aim to harmonize and set a common expectation for rigorous transparency in the form of a protocol. Currently, the core committee is working on pressure testing a draft template with a variety of use cases, including active comparator, new user design effectiveness studies, nested case control studies, an example of new oncology therapy compared to standard of care, a pregnancy safety study, self-controlled study, as well as the impact of benefit design. We're aiming the deliverable to align with the ICH timeline for producing recommendations. But that said, our harmonized protocol template is intended to be broadly applicable to pharmacoepi and outcomes research outside of regulatory purposes as well. And finally, I'll briefly mention the Transparency Initiative, which is a multi-stakeholder steering group that's currently focused on encouraging a more widespread culture of transparency through routine registration of hypothesis evaluating real-world data studies. And this group is focused particularly on practical steps, logistical barriers, and incentives toward registration. There are already two major study registration sites, clinicaltrials.gov, which is intended for trials, and EU Pass, which is particularly geared for post-authorization, usually safety-oriented studies for European regulatory purposes. But for HEOR, HTA, and other data science researchers who don't already have a mandate or workflow for study registration, the RWE registry is a simplified platform that is specifically designed for studies using real-world data. The registration process has been streamlined to include only a limited set of questions about the study and investigators, followed by the required upload of a more detailed protocol. The registration is automatically linked to a project wiki space that allows registrants to store and share code, appendices, and other supporting materials related to the project, all of which comes with a citable DOI that can be linked to the investigator's ORCID ID. There's also an embargo feature so that the protocol can be stored privately while the study is being implemented. In phase 1 of this site, the uploaded protocol will be allowed in any shape or form that the investigator wants to use. But in phase 2, the intent is to become more stringent in the standards for uploaded protocols to increase the usefulness of registered study information. And the hyperlink for the registration site is shown on this slide. I'll conclude with my usual 2x2 table that I always show to highlight the point that study transparency does not equal high study validity. We want to have both, but they don't always co-occur. And as we saw with the repeat project, we are able to reproduce biased studies quite closely if the study implementation decisions are clear. But when key implementation decisions are not communicated clearly, even rigorous, well-designed studies can be difficult to reproduce or assess for validity issues. So thanks for listening. Here are some references for the selected efforts that I discussed today, and please feel free to reach out if you have questions. But now I'll turn things over to Bob Ball from the FDA.
So can you see my my slides?
No, it's still on Zoom. Yes, this is perfect.
No.
If you can, yeah, if you can put them on full screen.
Bob, are you looking for the presentation mode?
Yeah.
So at the very bottom of the slide, in the almost right there, yeah.
Yeah, it's not responding.
Oh,
You can also try the slideshow option. Yeah, that's right.
Yeah, none of it's responding. I don't know why. Hold on. Is that
Yes, that's perfect. Thank you, Bob.
okay? All right. Thanks for including me in this panel discussion. I'm going to try to focus my talk on FDA's real-world evidence framework to support regulatory decision-making for drugs and biologics. There we go. I have no conflicts of interest to disclose. So I'm going to focus primarily on an overview of FDA's real-world evidence program, and then have a brief tie-in at the end to the Sentinel system's efforts for FDA's understanding of real-world evidence generation. So FDA put out a real-world evidence framework in 2018 that applies to both the Center for Drug Evaluation and Research and the Center for Biologics Evaluation and Research. And it's a multifaceted program that includes internal processes, stakeholder engagement, demonstration projects, some of which you've heard about already, and guidance development. And this is all based on the 21st Century Cures Act of 2016, which required FDA to establish a program to evaluate the potential use of real-world evidence to support new indications for a drug approved in a traditional fashion or to satisfy post-approval study requirements. And the work that FDA has been doing is describing priority areas, remaining challenges, and potential pilot opportunities that the FDA RWE program will address. And so there's a series of draft guidances that will be issued by the end of this year. And the first one, Keith Marcello already spoke about, was released just at the end of September, and that's on claims NEHRs, I think a particularly relevant topic to this audience. Importantly, though, the standard for substantial evidence remains unchanged, which means that the quality of the real-world evidence studies has to be extremely high. And you've already heard in the prior speakers a whole range of efforts to make sure that that's possible. So there are two definitions that I'd like to just briefly touch on from the framework. One is on real-world data, and the other is real-world evidence. And in particular, I'd like to emphasize that real-world data includes medical claims, electronic health records, registries, and digital health technologies. And in particular, medical claims NEHR data is one of the initial focus areas for FDA. Real-world evidence is the evidence regarding the use and benefits or risk of a product derived from analysis of that data. And again, importantly, although we've been talking a lot about observational study methods, this can also include randomization in the real-world setting, or the use of real-world data for externally controlled trials. So there are three key considerations for the FDA's RWE framework. And we've already heard a lot about these: whether the RWE are fit for use, whether the trial or study design used to generate the evidence can provide adequate scientific evidence to answer the question of interest, and whether the study meets regulatory requirements. So with respect to fitness for use, the RWE data sources, as I already mentioned, can include claims, EHR data, registries, device-generated data, or patient-generated data. And it's important, I think, to I just tie this back to some of the prior speakers' presentations, but particularly Keith Marcello's discussion about claims and EHR data and how the quality, how important quality checks are to ensure that data is fit for use. And Keith touched on a lot of these issues, challenges such as missing data, how to capture unstructured data, how to report data consistently. We've also already heard about timing of assessments and how they differ in clinical practice, and how they can be non-standard and how important that is for making valid inferences. Suitable outcome measures for disease progression might not be used in real-world data, or they might not be recorded consistently. And then there's important linkages that might be needed for studies across healthcare systems. The other important area that we've also heard a lot about from Sebastian was the Rwe Study Design, and that's whether the trial or study design used to generate RWE can provide adequate scientific evidence to answer or help answer the regulatory question. And I'll just point out at the bottom here, the FDA published a paper titled Randomized, Observational, Interventional, and Real World, What's in a Name, to try to sort out some of the terminology and how confusing it can be when talking about this. And I think this is an important point to understand that we have a firm baseline and standard to facilitate communication. And this slide is intended to illustrate the spectrum of study designs and how they interact with real-world data. So up on the top, we have on the left randomized or interventional studies, and then moving towards the right, non-randomized interventional studies, on all the way to non-randomized, non-interventional. And then on the bottom, increasing reliance on RWD. And so all the way over on the left, we can have a traditional randomized trial that used elements of RWD, for example, to assess enrollment criteria and trial feasibility, or do site selection, or even to identify outcomes, or maybe mobile technologies used to capture certain endpoints. And then there might be randomized trials with pragmatic design elements, and that's really setting the trial in the context of the real world setting, real world practice setting. And single arm studies using an external control, where the external control might include real world data. And then all the way on the right, we get into observational studies. And we've been focusing mostly on the use of existing databases in this talk, but it's also important to recognize that there can be prospective data collection in real-world data, including for registries or a prospective cohort. And lastly, the last part of the framework is the regulatory requirements. And this just harkens back to the requirement for substantial evidence. It's unchanged. And at a very high level, the goal is to distinguish the effectivity of a drug from other influences, such as spontaneous change in disease course, placebo effect, or bias. And there's many common practices. We've heard a lot about some of these already. Control of confounding, blinding, standardized outcome assessments, adjudication criteria, and audits. And now I just want to briefly sort of circle back to Rishi's presentation and talk about how the activities in the Sentinel system support FDA's understanding of RWE generation. So in 2019, FDA put out a strategic plan for the Sentinel system. And as you can see here, it has 5 main areas that are relevant to, I think, in a sense, this issue of how data is obtained from EHRs in particular. So natural language processing, advanced analytics such as machine learning for outcome validation, looking at novel data sources and how they can be linked to claims in EHR data, in particular things like apps that might capture patient-generated data, how to do improve data interoperability, and this is particularly important when thinking about different common data models and how information is the same or different within common data models, and then to looking ahead to exploring disruptive technologies. And so FDA launched in its newest Sentinel contract in 2019, a three-center approach. The first center is the operations center, which focuses on doing analyses and expanding the data infrastructure. We have a communication and outreach center to reach out to different stakeholders. And most important for this talk, the Sentinel Innovation Center, which created a master plan to implement the goals of the FDA strategy. And as Rishi already pointed out, there were 4 pillars to that: the data strategy, the feature engineering, causal inference, and detection analytics. And the Innovation Center also has a series of webinars that are open to the public and also available online to hear about the approaches to all these different topics. So in summary, FDA's real-world evidence program for drugs and biologics is advancing as outlined in the agency's 2018 RWE framework. FDA has issued its first guidance on claims and EHRs. And the Sentinel System Innovation Center Master Plan provides a roadmap for improving RWE generation capabilities. And I'd like to acknowledge John Concato, Joe Pan, the FDA Sentinel program team at FDA, and the Sentinel partners. Without whom a lot of our work in this area wouldn't be possible. Thank you.
Thank you, Bob, for that excellent concluding remarks. With that, let me thank the AMIA Programs Committee for providing us the platform to discuss our work and initiatives at the FDA Sentinel Innovation Center. And thank you, everyone, for listening. And thank you to all our panelists for their excellent presentations. With that, we will stop the recording. Thank you.